This model also recognizes that the organism will work perfectly well without maintenance, at least for a while. We watch teenagers having horrible diets, and they don't seem to suffer from it then. But think about it. If you don't change the oil in your car, it still runs perfectly well. It's just that it wears out sooner. And therefore, this reconciles what I think has been a troubling paradox for many scientists, that how could you be deficient without being sick? Well, of course, under this kind of a scenario, that's easy. You're just not taking care of your body adequately, and it is wearing out. So it'll function for a while. But it's also about squaring what we call the morbidity or mortality curve. Several years ago, Jim Fries from Stanford pointed out that probably the average human lifespan under optimal conditions is about age 85, with what statisticians call a standard deviation around that number of about 5 years. So that by the time you're 10 years under 75, everybody's still alive, and by the time you're 10 years over it, then most everybody's dead. Or if we look at the survival curve, it's just the mirror of that. Most everybody's still alive at age 75 under ideal conditions. But of course, we know that's not true. And in the industrialized nations, we have a curve that follows a line something like that. That gets changed because of war and other issues, but that's about it. And what we're concerned about here is this gap between those two lines, and that's what we mean by squaring the mortality curve. The presumption, of course, is that nutrition has a powerful role to play in this improvement. And if you doubt that, certainly various national programs such as the National Cholesterol Education Program or the Dietary Guidelines for Americans, which are produced every 5 years, show very clearly that this is why it's important to do all of these things. Because it will improve your chance of living healthy for a longer period of time. And vitamin D comes into this, and it's the topic of this presentation. Now, to show some of the evidence behind that kind of a conception, here's a paper that was published just a year ago from the Baltimore Healthy Aging Studies 1 and 2. It's a group of individuals who were followed for 6 years, and the chart on the right shows the curves for dying for the lowest quartile of vitamin D status, second quartile, third quartile, and highest quartile. And you see a lovely, what we call dose-response relationship there. And these are the boundary values for these for the top and bottom quartiles. That's under 15 nanograms. That's really low, as the two prior speakers have stressed. And the top quartile is still not high by any means. It's over 27 nanograms per milliliter. But even so, there is a twofold better chance of surviving at the end of that 6-year period of time if you were in the top quartile than if you were in the bottom. Now, to step backwards, vitamin D exists in two chemically distinct forms. One's called vitamin D2, and it comes from plant products, and vitamin D3 is the animal source. It's what we make in our own bodies. It's what we make with UVB exposure in the skin. Serum 25D is the way vitamin D status is evaluated, and the lower end of the acceptable range has been creeping up over the years. Carol stressed the importance of getting to 40 or 50. The scientific community is not there yet by any means. And there is some begrudging acceptance of a value as low as 30 to 32 nanograms per milliliter as the lower end of the normal range. And what I want to do is to ask what's the basis for even that number, and how long will that hold before we revise it upward still further? Well, the basis comes from studies performed in our laboratories at Creighton here in Omaha. And what we see in this slide on the vertical axis is the fraction of the amount of calcium in your diet that you absorb under test conditions. And on this axis, we see the serum 25-hydroxy-D expressed in nanomoles per liter, which is 2.5 times what the nanograms unit would talk about. So you can see immediately here, it doesn't take much imagination to see that there's kind of a threshold or plateau that is produced at about 80 nanograms per milliliter. Now, what that means is that once you get up to that plateau, physiological regulation of calcium absorption is no longer limited by vitamin D availability. But you see, on the ascending limb of that curve, if you have low vitamin D status, you don't absorb calcium as well. Now, the one thing we all remember from nutrition units in school is you need vitamin D for calcium absorption. And this is simply a depiction of the quantitative relationship between how much vitamin D you have and how well you're able to control calcium absorption. It's important to stress that the vitamin D does not cause calcium absorption. It merely enables the body to regulate calcium absorption. So if you've had a high vitamin D status because you've been a lifeguard working out all summer, getting lots of sun exposure, that doesn't mean you're going to have high calcium absorption. It means simply that you can if your body needs it. But if your body doesn't, then you downregulate it, as these arrows show. And conversely, if you don't have enough vitamin D status, you try to do some upregulation, you can't get very far. So the body is enabled to control calcium absorption with adequate vitamin D status, and it can't do it without enough vitamin D. And so we can think of this, and I'll come back to this point in a couple of moments. We can think of calcium absorption as having a threshold point at some point along this vitamin D status axis, which is about 30 nanograms per milliliter. Rickets, as we've already seen in the chart that both Carol and Mark used, is preventable at much lower levels. And so we have the same threshold diagram, but you get there much sooner. Now, if you have enough vitamin D to prevent rickets, does that mean you have enough vitamin D to optimize calcium absorption? Clearly you don't. How common is vitamin D deficiency? Here are data from a study that we completed a couple of years ago in Fremont, Nebraska, involving nearly 1,200 healthy women over age 55. These values are adjusted for season, and this is a frequency distribution of these values, and you see that they follow a beautiful normal curve, a typical Gaussian curve, with a mean value of about 71 nanomoles, which is about 29 nanograms, better than a lot of populations, but they're semi-rural women and had more outdoor exposure under the circumstances. But if we were to take 32 nanograms or 80 nanomoles as the lower end of some sort of an acceptable range, you see that we're dealing here with 65% of even this relatively healthy population having values below 80 nanomoles or 32 nanograms. And if we were to go up to 100 or 120, and 100 nanomoles is 40 nanograms, we would have 80 to 90% of that population being vitamin D deficient. Well, the problem is even worse for kids. This paper was published last fall in the journal Pediatrics. It comes from the National Health and Nutrition Examination Survey in the U.S., 2001-2004. In this case, it was girls, 3,000 of them, segregated as we see here. This is Caucasians, this is African Americans, and this is Hispanics. We've lost the bottom here, as is true for so many of the slides with this projection facility. Now, what the pink bars show is the fraction that were below 15 nanograms per milliliter, which is clearly deficient by anybody's standard. And the white bars take you up to those who were between 15 and 30. And take a look, if you will, at teenage black girls. 98% have values below 30 nanograms per milliliter. Hispanics are intermediate there, again, teenage girls there, about 90%, and Caucasian girls, who are the best off under the circumstances, still better than 60% are vitamin D deficient under the circumstances. It truly is a serious epidemic. Now, without belaboring that point, I can assure you that in virtually all nations, irrespective of latitude today, the majority of the population has inadequate vitamin D status. The chart from Cedric Gardland that both Carol and Mark showed you are data that were obtained before we started to move indoors so extensively in the last 10 to 20 years. Because now, whether you live in Florida or Alaska, you're likely to have pretty much the same 25-hydroxy-D level. That's the bad news. So what are the consequences of that? Well, there is good evidence with respect to this broad array of disorders. Bone diseases such as falls and fractures, high blood pressure, increased risk of cardiac disease and death, increased risk of prematurity, low birth weight, and increased risk of cesareans, diabetes and the metabolic syndrome, both type 1 and type 2 diabetes, periodontal disease, decreased resistance to infection, various cancers, which have been stressed already, and increased risk of multiple sclerosis. Now, this list of disorders is almost mind-boggling, and this has to be trying to sell snake oil. But I can assure you it's not. I'm going to show you a couple of examples from the published literature. This has to do with fractures. It's a study that was published in the British Medical Journal 7 years ago. It's a 5-year randomized controlled trial, treatment with vitamin D in a dose of about 800 international units per day. Started a long time ago. I'm sure we would have used a larger dose today, but that's what they used when they started this trial. And what that did is to raise the serum 25-hydroxy-D from 53 to about 75 nanomoles. That's about 21 to 30 nanograms per milliliter, getting them up to the lower end of that range that has been accepted previously as normal, up to 30. What they looked at was osteoporotic fractures. And here's what they found. The control group on the left-hand side here, given a relative risk of 1.0, as is the usual convention, whereas the treated group had a 33% reduction in osteoporotic fractures, hip, forearm, and spine particularly, over this 5-year period of time. This is what's called in the field level 1 evidence. It's double-blind, placebo-controlled randomized trial, the strongest kind of evidence that's available. Here's another study looking at the risk of falling. 122 women from South Germany, aged 63 to 99. They had low 25-hydroxy-D values, 12 nanograms. It's a short-term study in which they compared either calcium or calcium plus vitamin D in a 12-week study to look at the frequency of falls. Again, this was a randomized controlled trial, double-blind, placebo-controlled. The calcium-only group, a relative risk of 1.0. The calcium plus vitamin D group, that is getting vitamin D, nearly 50% reduction in falls within 12 weeks. Good to know that you don't have to do this for years in order to get a benefit. Some of that, of course, is due to improved neuromuscular function. This is from the Amsterdam longitudinal aging study. Over 1,300 men and women, average age 75. Their neuromuscular performance was measured in their own homes on a scale of 0 to 12, with higher being better. And here's what you see. Serum 25-hydroxy-D expressed in nanomoles per liter. There were so few people above 75 in Amsterdam that they couldn't really take this much further. So the top quartile starts at 75, which is 30 nanograms. So only 1/4 of this population would have been above a level that we would have accepted as acceptable for calcium absorption efficiency. Now, each one of these steps was statistically significantly better than the others, simply because it was a big study. It was easy to do that. So you're much less likely to fall, and therefore much less likely to break something as a consequence of having better vitamin D status. We move to another system entirely. Here's another randomized controlled trial published as much as 9 years ago. 148 women, double-blind, placebo-controlled, treated for 8 weeks, just 8 weeks, with calcium and vitamin D. Now, calcium alone is known to lower blood pressure modestly. And the question was not whether it would do it again, it will, but whether adding vitamin D would improve it. And here's what we see here. The 2 bars on the left-hand side are for calcium only, and the 2 bars on the right-hand side are for the combination of calcium plus D. And the solid bar is the baseline value, and the open bar is the end of treatment value at 8 weeks. And what you see here is that there was a reduction in systolic blood pressure in both groups, but better than twice as much in the calcium plus vitamin D group. And these differences were statistically significant, and the differences between the 2 treatment arms were statistically significant. So here's another system in which we see a beneficial effect of vitamin D.